this new instance that's popped up of a patient getting COVID-19 for a second time from a slightly different strain. Today, what I want to talk about is the risk of reinfection. So some people posted this in my Discord yesterday, right? And I haven't really had the chance to read it, at least the original research. Okay. But Hong Kong reports the first case of virus reinfection. So I did want to learn a little bit more about Hong Kong, who's reporting the first case of virus reinfection. Okay. There was a report of reinfection. Maybe you remember this, maybe you don't. About 3 months ago, there was kind of like this bubbling beneath the surface in the media that there was reports of a reinfection. Ended up not being verified. This looks legit and is clearly a clinical diagnosed reinfection. Hong Kong scientists are reporting the case of a healthy man in his 30s who became reinfected with coronavirus 4.5 months after his first bout. Genome sequencing shows 2 strains of the virus are clearly different, making it the world's first proven case of reinfection. So maybe there was reinfections before of the same strain. Yeah, no worries, Fomex. Welcome on in. Maybe there was reinfection before, but we didn't have a way to really verify it, right? By sequencing the genome of the virus, we can see that they're distinct. So he's been infected twice with 2 different strains. There's a lot of different strains. The thing continues to evolve. Thankfully, right? My opinion, and from what I've read, it's my belief that many of these strains are going to have the same treatments. So it's not as if a single strain is going to require an entirely different vaccine. That is probably not the case, because they still operate on attacking and getting into the cells the same way. So he's going to probably have nearly the same treatment, although we've gotten better in the months since he had it the first time. But you understand my point is that, you're probably treating these 2 different strains the same, as long as we have the same things available at the same time. So this is distinctly and definitively the first evidence we have of a reinfection. Okay, the WHO warns it is important not to jump to conclusions based on the case of one patient. For sure, reinfection might not be that prevalent. This might be an outlier, right? They might be rare, and they might not be that serious. Maybe he's built up antibodies, and his progression through this second version of coronavirus is much, much better, right? And he's built up an immunity. Even if that's the case, it's still not a great sign. It's still not a great sign. Okay, and I'm really interested to follow and learn more about what were his symptoms round 2 versus round 1. Okay, you can catch it twice clearly. It might have to be different strains. Is the response any better? Is this guy a clear outlier? In other words, is his immune system deficient in some way that made him especially susceptible where 99% of us would not be? Right? Slayer, not necessarily. You frequently will need 2 rounds of shots just for the single strain. And for coronavirus, we might, but it's not that we're going to be needing 2 vaccinations for these 2 different strains. We don't know that yet. Spee says the guy's second infection was quite mild, so his first infection might have partially protected him. See, I think that might be actually worse news, Spee, if that's the case, because that suggests he's probably like normal immune response, such that 99% of the world is at risk of catching it more than once. But I guess, it's half full, half empty. Does him being normal and having a better response the second time around, right, mean, well, shoot, that means if he's normal and immune response and he can catch it again, then we can all catch it again? Or does it mean, thank God his symptoms weren't as bad the second time? Yeah, Uncle Elias, we'll get to that. That's exactly what I want to go over. And thank you again for linking that, because I wouldn't have found it otherwise. 23 million cases of coronavirus infection around the world. Those infected develop an immune response as their bodies fight off the virus. The strongest response has been found in the most seriously ill patients, and they've also found that in the most seriously ill, they generally have antibodies that last longer. than mild or medium symptoms. The report at the University of Hong Kong says the man spent 14 days in hospital before recovering from the virus, but then, despite having no symptoms, tested positive for the virus a second time, following a saliva test during airport screening. It's expected the virus will naturally mutate over time. Given the number of global infections to date, seeing one case of reinfection is not that surprising, even if it is a very rare occurrence. Fair. It may be that they're not as serious the second time around. Okay, so let's look into the paper and read it. Thank you, Uncle Eyes. The second test was several months after, not like a couple weeks. So it's definitely, and genome sequencing has confirmed it's a different strain. Svi says his first infection was mild. His second was symptomless, but was discovered later. So that's good, Svi, I think. Yeah, sorry, nerve toucher. Lego logging, can it overshoot in preparing antibodies? I don't know. I don't have enough. Sarah, welcome on in. Good to see you. I don't have enough knowledge to know. My guess is you could start to get some sort of autoimmune reaction if that's the case. Yeah, but Mendelator, it's not like the virus itself that is doing the killing, right? It's the body's symptomatic response. So I don't know if there's a correlation there or not. COVID reinfection by a distinct SARS coronavirus 2 strain. Okay, the University of Hong Kong, I'm going to guess, is a pretty prestigious, legit university. This is a preprint, right? I believe this is a preprint, meaning it's not gone through the full peer review process. But in the age of coronavirus, any paper that has to do with COVID-19 and the coronavirus, usually they put the results out there while it goes through the peer review process, because that peer review might take 1 month, 2 months. I've had some go 6 months long. Okay, and 6 months from now, this news may be worthless. Okay, so you have to understand that even though it's not peer reviewed, right? That's for a reason. They're waiting for peer review while they release this information to the world. So they did whole genome sequencing on respiratory specimens collected during 2 episodes of COVID-19 in a patient. They've done the PCR. The second episode, asymptomatic infection. So yeah, here you go, Uncle Elias, you're right. Or was it Svi? The second infection was asymptomatic. Occurred 142 days after the first. So it's not like 2 weeks later, he still had the virus and tested positive. Second episode was asymptomatic. The second episode, there was evidence of acute infection, including elevated C-reactive proteins. The viral genomes were different, so there was different strains he was infected by 142 days apart. Yes, okay, Mendelator, so I see what you're saying. So yeah, I mean, if the death rate is immediate and only lasts 3 to 4 days, then right, there's not this time for the patient to go out and spread before they're symptomatic. So that's true. I just don't know, we're so far from Ebola with this thing, right? Because generally you have it for a few days without any symptoms, right? And then you have light symptoms and then they get progressively worse, that it could mutate fluctuating a day in either direction and we wouldn't really notice in terms of the appearance and disappearance of symptoms. The first virus in his infection was related to strains collected in April 2020, while the second was closely related to strains collected in August 2020. The patient has reinfection instead of persistent viral shedding from first infection. Our results suggest SARS-CoV-2 may continue to circulate among humans despite herd immunity due to natural infection. Oh, that is
bad news, everyone.
That is bad news. May continue to circulate among humans despite herd immunity. So much for herd immunity. Although, here's the qualifier, right? This is still a preprint. It's still one person, but it's not a good sign. Further studies of patients with reinfection will shed light on the protective correlates for guiding vaccine design. Yikes. If I recall correctly, the patient left Hong Kong for Spain after the first infection, and upon return to Hong Kong, he again tested positive. 33-year-old male in Hong Kong. He enjoyed a good past health. During the first episode, he presented with cough and sputum, sore throat, fever, and headache for 3 days. So typical, I think, young. I was going to say middle age, but 33. I'm gonna go with that's young, right, chat? Yeah. 33 is young. He's a young man, right? 33 is young, not middle aged. So young 33-year-old male residing in Hong Kong enjoyed a good past health. So I think if a young male with good past health caught it, these are sort of the average, moderate symptoms. He's not asymptomatic, but he has moderate symptoms, right? He took a test, PCR confirmed positive on March 26, 2020. He was hospitalized, so it did get worse. So he had, I would say, moderate to aggressive symptoms for a 33-year-old. By the time he was hospitalized, his symptoms have subsided. Oh, maybe not, moderate symptoms. He was discharged over 20 days later. Dang. 19 days later. After having 2 negative swabs, taken 24 hours apart. So in April, this is what China was doing, right? If you test positive, we're going to put you in a hospital bed for 2.5 weeks. Yeah, he's a toddler. Thank you, Bria. Yeah, we need way more data, Svi, for sure. But it's still, this news is worse than no news on the subject. During the second asymptomatic episode, so he had, I would say, moderate symptoms, which means he probably built up sufficient antibodies. Now, we've seen that people that are asymptomatic or people that have mild symptoms, their antibodies go away in 45 days. And this is 100 and some days later. But he had moderate symptoms, so we might expect that he might still have some antibodies built up. Okay, and those antibodies were effective in making the second strain of COVID-19 asymptomatic, or the second strain simply is different enough to make it asymptomatic. I think probably the former. The patient was returning to Spain, to Hong Kong from Spain via the UK, and was positive at entry screening to the Hong Kong airport. He was hospitalized again and remained asymptomatic all along. So even if you're asymptomatic and test positive, you're hospitalized. Physical examination was unremarkable. Oh, feels bad for this guy. This is worrying, but might have been an anomaly. Yep. Yeah, for sure. That's a perfect way to sum it up, and I would agree. No antiviral treatment was given to the patient. He was asymptomatic. PCR values decreased during hospitalization. Increased. So he had a reduction in viral load throughout hospitalization. The first viral genome, his first infection, was definitively different from his second infection. And only by sequencing the genome are we really sure about that, right? You can't just look at the symptoms and say, oh, well, it's different symptoms in this guy, so, clearly it's a different virus that he's being reinfected with. No, it could be like a minor flu or something else. So nice that they found the positive test and then sequenced the genome to definitively prove these are 2 different infections. Several lines of evidence support that the second episode is caused by reinfection instead of prolonged viral shedding. Right, it's not the same virus that evolved inside of him. If you hospitalized for 20 days everybody that tested positive in the United States, we would be way past capacity. Right? That's what they're doing, it seems like, in Hong Kong. Unless they hospitalized this guy because he showed another positive infection. I'd have to look into that, but their numbers might be or must be very, very low for a healthcare system to be able to support hospitalizing everybody that tests positive. I don't want to hold that bet. Like, no, I would like to update that. But let's see how it progresses over the next couple months and see what happens with the United States election. 133 over 94. I would not consider that as good pass health. They don't give his BMI. No, it's not the United States, so I don't want to make any assumptions about the average BMI, but that's a fair point. I don't want to speculate, but this makes me think: does he have underlying or long-lasting heart issues from the first infection? That would be bad. Yeah, exactly. Devil missing Jones. Too much speculation, but that would be terrible if he didn't have blood pressure problems and now he does since he had COVID. That's really the scariest part, in my opinion, of all this. Yes, it can evolve, but I'm somewhat hopeful in the progress we're making towards a vaccine, that by April, May of next year, we can have vaccines. And that development will go a long way to treating any other mutations that aren't affected by this vaccine that we produce. The scariest part is people that get it, have moderate symptoms or severe symptoms and recover. What are the long-standing underlying issues, right? Scar tissue, more susceptibility to lung cancer or heart disease down the road. That's really scary to me. And we still don't know because we, don't have people that have had COVID-19 for 5 years yet. I want to see what they say about T cells, if anything. Here's the genome analysis. This is where I want to go. 142 days between the first and second episode. Viral RNA is undetectable 1 month after symptom onset. So it definitely wasn't just a reemergence of the same virus. Patient recently traveled to Europe, where resurgence has occurred since July 2020. So I'm wondering, is the genome they detected the second time around similar to the strains that are actively going on in the UK, wherever he traveled to, Italy? Reinfection has several important implications. First, it is unlikely that herd immunity can eliminate SARS-CoV-2. Although it's possible that the subsequent infections may be milder than the first infection, as for this patient. Now, taking this patient, as we've said recently in the chat, taking this patient and extrapolating to all of humankind, is dangerous, but still not a good sign. Will likely continue to circulate in human population, as is the case for influenza, for example. In some cases, reinfection occurs despite a static level of specific antibodies, like the flu. Second, vaccines may not be able to provide lifelong protection against COVID-19. Ugh. Vaccine studies should also include patients who recovered from COVID-19. Dang, man. Does anybody know if the phase 3 trials for a lot of these vaccines are treating patients who recovered? My guess is no. My guess is that population has been removed. This is so complicated, It's just going to continue to evolve in terms of what we have to check vaccine development for. Now we have to make sure the vaccine that we're developing for COVID-19 doesn't have adverse reactions in those that recovered from COVID-19. I know, Lega. I think the anti-vaxxer movement is decreasing, which is a good sign. Yeah, Jan, diminished lung capacity is a huge symptom. Just constantly being out of breath and lack of being able to sustain any sort of energy level. It's sad. I don't want to get too bummed out. I know it is a terrible thing that's going on, and only science is going to help us get through it. So I'm thankful to have all of you hanging out on stream as we go through this paper and try to learn about this evidence of reinfection, which looks legit. How much we can extrapolate from a single person, only time will tell. But this at least provides a blueprint for how you can identify reinfection. And maybe a month from now, we have several more cases coming out of China like this. I mean, that's what we have to look to. And unfortunately, since it started there and they had the earliest cases, we're going to be expecting them to release this kind of data for reinfection. And it's good to at least see this. EPI says composition of phase 3 groups is unknown. Thank you. Spain is having a spike. We can look at that shortly. Oh my gosh. You guys can't believe we're talking about coronavirus and we didn't even use the coronavirus intro. Jim, cue the coronavirus intro. Okay, now we can officially, right, now here we are. Okay, now we can officially talk about COVID-19. Another lockdown because Spain is having a huge increase. All right, let's look at Spain right after we get through the rest of this paper, at least the discussion portion. We don't have to read every single reference, but let's look at Spain. I want to see that and see, compare how Italy is doing. Neurological problems post-COVID, for sure. From experts I talked to in biomedical research, heart and lungs are their biggest concerns, but yeah, you're not ruling out anything. Could be kidney problems. Neurological for sure. Yeah, Jim's the best. Jim's the best. I keep him tucked in a small closet. You can, well, I'm not sure if you can see or not. I'll show you on the other cam. I tuck Jim. You see, you're not going to be happy with me, but Jim. Wait. How do I, here we go. Jim is in that closet right over there. That's what I keep him in. Feels bad to be Jim. But he does excellent work. He does excellent work for the team, the Prof Melko team here. Jim, what are you working on right now? Can we take a look? Oh, more microscopy? Gotcha. Okay. Yeah, no, keep doing microscopy. That's good. Back to coronavirus news. What is going on? Am I in Jim's suspension? Whew, okay. Thanks, Jim. All right, let's get through this paper for sure. A previous study of reinfection in rhesus macaque, did I say that? Educate me, chat. Also showed a milder illness during reinfection, likely related to the priming of the patient's adaptive immunity during the first infection. Okay, so it mostly is probably due to T cells or antibodies. In our patient, although anti-SARS-CoV-2 antibody was not detected initially during the second episode, it still might have partially controlled the virus. This is a huge sentence as well. Macaque. Okay, well, I have 3 different pronunciations in the chat, so macaw. Okay, no, so rhesus okay, also showed milder illness. All right, thanks, chat. Interestingly, this patient of reinfection did not still have antibodies present, and this is probably not surprising. We've seen some literature that suggests for mild or moderate symptoms, antibodies don't last past 45 days, and this looks similar. Now, he was hospitalized, but I would say moderate symptoms is where he was at. He wasn't super severe. Those are the people that get antibodies that look like they last a long time. So this is probably not surprising based on what we know. But it doesn't mean he had low amounts that can be detected that helped control the virus the second time. variations in the spike protein may render the virus less susceptible to antibodies, which were introduced during the first infection. So if this other strain that he caught, right, had some variation in the spike protein, yes, the antibodies would be ineffective. Now, by and large, from what I've read, a lot of the different strains have similar spike proteins. Although mutations of the spike protein have been seen and do reduce susceptibility to neutralizing antibodies. There are four, this is important too, there are 4 amino acid residues that differ in the spike protein between the first and second infection. So they know the part of the genome, right, that codes for the spike protein. And these 4 had different sequences between the two. So look, whether this is a one-off and not very prevalent, or whether it's a sign of things to come with reinfection, this line right here could be huge. Identifying, even at this stage, right, that these are the areas of the genome and this that are different between these two that are able to reinfect, right? And maybe people start working on pinpointing, you know, what are the structural differences that these genomes are coding for. Okay, so even if this happens to be a one-off, it's, you know, important that this is released and we know perhaps what areas we need to study further. So these tests to look for antibodies in the blood, if the antibodies are below the lowest level of detection, you say they don't have antibodies, but they might just have a few that are still good enough to help fight off the infection. Remember, this guy didn't have symptoms the second time around. T-cell immunity is the other thing. Remember, in fighting off coronavirus, you know, it's about your antibodies and it's about your T-cells, right? Antibodies we don't think stick around past 45 days for mild to moderate symptoms, okay? T-cells we have no idea about. T-cells may play a role here during reinfection. Studies on COVID-19 and other coronaviruses showed that coronaviruses can induce long-lasting T-cell immunity, where these T cells target the structural proteins. So this is good. While antibodies may be waning, T cells might be longer lasting. Antibodies were undetectable in the blood collected shortly after the diagnosis during the second episode. The low antibody level may be related to his mild illness. We and others have shown that patients with mild disease had lower antibodies than those with more severe disease. Yes, this is what I've been talking about. With mild or moderate symptoms, after 45 days, you don't have antibodies. One possibility is he didn't mount any antibody response after the first infection, but we only have serum collected 10 days after the onset of symptoms. Sometimes you don't see the antibodies until 2 to 3 weeks after the symptoms. So he might have actually had antibodies that helped fight off the first infection, right? They're not sure. Waning of antibodies has been well described. In one study, 33% of recovered patients were negative for antibodies during the convalescent phase, right? This is what I'm talking about. After 45 days, right? Medium, low to moderate symptomatic patients don't get long-lasting antibodies. Asymptomatic individuals are negative within 8 weeks after onset of symptoms, 40% of them. Besides the lack of protection against reinfection, another implication of rapid decline in antibodies is the seroprevalence studies may underestimate the true prevalence of infection. Right, I didn't even think about that. This is crazy. Yes, the rotating graphic right down there is a rendering of the coronavirus. I'm not sure how accurate it is anymore, but it was at one time. An artist representation of images of the coronavirus. All right, so this is pretty big. The lack of prevention against reinfection, besides the lack of protection against reinfection, an implication of a decline in antibodies is that our studies of how prevalent the disease is may underestimate the true prevalence of infection, right? So, you know, when we're testing people with antibody tests to see if they've ever had it, if your antibodies are gone in 45 days, right? I just got tested 2 weeks ago, okay? And if I was asymptomatic, had low symptom levels, and I had the thing in March, April, May, the antibody test wouldn't have detected it. And so we wouldn't know the true prevalence of this thing. The lack of antibody response after COVID-19 can have implications of both susceptibility and the severity. If the patient is asymptomatic during the second infection, it's possible reinfection in other patients may result in more severe. Sure, we're only studying one person here, it's hard to extrapolate. There are several limitations in this study. First, only one specimen was collected from the first episode. TLDR, there's several limitations. It's one person. That said, it's not good news, right? It's not a good sign that you can catch different strains and be infected again and spread it to others. Reinfection can occur even just after a few months of recovery. SARS-CoV-2 may persist in humans, as is the case for the common cold. Not good. Even if they've acquired immunity via natural infection or via vaccination. So herd immunity might not be a thing, which is really sad. So, Uncle Elias, thank you so much for linking the paper in the Discord. I mean, I have mixed reviews about this study. It seems like legit, sound scientific research from a strong university, University of Hong Kong. It's bad news that we can have reinfection, right? Because just because we, vaccinate against a current strain, a couple months later, you could catch a different strain. And maybe you're asymptomatic the second time, but your grandma might not be. The same is true for the flu, and we still vaccinate against it. Yes, of course, I think, the notion of achieving herd immunity might not be as promising as we thought. We're still going to develop vaccines. All of our work on vaccinating, our current vaccination efforts are not going to be in vain. They're still going to be used for vaccinating all these different strains, right? If we need different vaccinations for them. And it's still beneficial to vaccinate, right? Like, I'm going to get my flu shot this week, right? Early, it just became available. Go get your flu shot as soon as you can, right? In hopes of lowering the overall toll that the medical system is going to have in December and January, right? In the cold weather seasons in the United States. So please, I urge you, if you can, to go get, and you're healthy enough to go get a flu shot as soon as you can. And I don't, I don't harbor resentment if you don't get the flu shot every year, right? That's your decision. That's fine. But this year it really is pretty important to get the flu shot to help. Thank you so much for the subs. To help lower the overall demand on our healthcare system that we will experience. Devil, Mr. Jones, we're getting flu shots next month. Excellent. Yeah, Chardell, if you can, please do it. Please do it. Kevin does chemistry. You're just in time for me to leave stream, right? For me to leave stream. Oh, Kevin's here? It's a total coincidence, Kevin. I gotta go. It has nothing to do with you. I was gonna get going, Kevin. It's not you, it's me. This is awkward.